Yeah. So up to 34% patients report in first few hours some discomfort and pain and redness, and it can persist up to 6 weeks. And most of the time, the thing which we prescribe, I will show you. So the possibilities, what are the possibilities? Which is swelling of the eyelids, subclavicular hemorrhage are very common. Allergy, dry eye are the next most common. Then there will be causes like Fuchs dystrophy and recurrent corneal erosion, increased intraocular pressure, endophthalmitis, of course traumatic surgery and root perforation. And the initial things which we give, it is artificial tear substitutes and NSAIDs like paracetamol. And if it does not improve the situation, then only we think of the serious ones. So I just discussed few of the more serious problems like the iritis, the photophobia and circumciliary congestion will be there. And usually there will be previous history of uveitis or maybe eventful surgery like vitreous loss, lens particles, iris injury or hemorrhage. Usually we get mild to moderate anterior vitreitis and definitely will not get much vitreous involvement. Management is conservative mainly. Then we get the raised intraocular pressure. Usually the visco will be left into the antechamber, then maybe the patient was previously glaucomatous. There will be definitely chances of vitreous loss, then lens particles and vitreous in the AC. And this is also treated by mostly conservative methods. So then we get the most dreaded two, the toxic anterior segment syndrome TAS and the endophthalmitis. So about the TAS, we care is acute severe reaction with vision loss, pain and raised intraocular pressure. Usually we get in 1 to 2 days post-op compared to the end of which we get after 3 to 4 days post-op most of them. And diffuse corneal edema with photophobia, severe antechamber reaction, maybe hypopia even. And the causes are described as bacterial endotoxins, BSS, denatured viscoelastics, etc. USGB scan will be definitely normal, and if we do AC and vitreous tap to rule out endophthalmitis, they usually come negative only. And these are the, we usually conservatively managed, mostly topical steroids, sometimes managed systemic steroids, results within 3 to 6 weeks, and made it surgery also like keratoplasty, AC was even some cases described with IOL removal. This is with the conservative management we can see, and this is after disc surgery. And usually if it persists more than 6 weeks, there may be irreversible damage and loss of vision to the patient also. Then the endophthalmitis, which is most dreaded among us. There will be decreased vision, pain, lid swelling, congestion, corneal infiltrate, definitely AC reaction with hypopia plus minus, and there will be defective pupillary reaction. So when we suspect, clinically we diagnose it with slit lamp, fundus giving and ultrasound, and then we treat promptly. See, so this is the progressive vitritis is the hallmark of any kind of endophthalmitis. So the most common thing which we, even the anti-SMS surgeons also sometimes send the patient to us thinking it is TAS. So the serial ultrasound is a very important thing, and if we are in doubt, we can always take ACT sample and give intravitreal and see for the result. So intervention, we do AC or vitreous tap with intravitreal antibiotics urgently for stain culture PCR, which can be done by anterior segment surgeons also. Then we usually prescribe topical antibiotics with topical steroids hourly with mydriatics, and also we prescribe systemic antibiotics. Vitrectomy if it is not responding or vision is less than hand movement in case of diabetics. Then particularly post-trabeculectomy, all those cases. This one small video which we do is looks like bad, but see if we treat them, it gives good results. So first we put a AC maintainer and remove the anterior membranes, which you can see because you cannot see anything much there. And then we clear the antivitreous space, and this is the 25 gauge we used. And then we can see the inside is there is lots of vitreous haze with pre-retinal exudates. So we clear them up with vacuuming, and then we cut as much vitreous as possible. But where we cannot see, we don't go rigid to that way, and we try to finish the end point. We keep it as the posterior pole PV, and we give the intravitreal antibiotic after that and see the result also. So this is the before and this is the 4 days after the core vitrectomy, and after 10 days it's nicely clearing. And thank you. And this is one invitation for our next AIOC 2023. Thank you.